For non-GI surgery, is alvimipam still in the protocol? Or do you have to have a bowel anastomosis?
In some protocols for gynecology, it's there, certainly gynecology, oncology. I know some urologists. And there are ongoing trials, I know, in spine surgery. But for the most part, it's in people with a bowel anastomosis.
That's correct, yeah. I think that's what the literature shows, that's what the data shows, and that's probably how they got the indication. But certainly it's being studied across various different types of surgeries.
I mean, it sounds to me, again, clearly it sounds like based upon its mechanism of action being this mu opioid receptor antagonist, that the key is as long as you got opioids in play as part of your postoperative analgesia, that, you know, this drug should be used.
And it doesn't take much. You know, there's one setting, colorectal surgery, that shows a single dose of 2 milligrams of Dilaudid will delay GI function. So, you know, while we've certainly reduced opioids, there's very few patients that are not going to at least receive, you know, 1 oxycodone or 1 dose of opioids.
Getting away from the old management paradigm where you start with narcotics, and then when that doesn't work well enough, you just give more narcotics and more narcotics after that. Getting away from that and really switching to this embracing of multimodal, non-narcotic pain management, it's been the thing that has really changed things dramatically and extraordinarily.
Yeah, I think we learned that early on in the urology literature, was that we used a lot of right before the patient woke up, you gave them the big slug of a intravenous nonsteroidal, and you used that, you know, really through the perioperative or the postoperative period, really trying to limit the amount of opioids that you gave the prostatectomy patients. You know, we were never so bold to use it in cystectomy patients, thinking that, oh my God, these patients are going to be so much worse. But I think all of you, I think we had talked about this in the break. So what about this IV acetaminophen? How does that play a role? I mean, is that a...
I got to tell you, I was so skeptical about the use of IV acetaminophen. I just couldn't understand how or why that would work better than oral acetaminophen. And at the time that it was introduced to me, I was still relying on narcotics for management of my patient's pain. And when I actually looked at the literature around it and began to employ it, I was really, frankly, amazed how well it worked. Now, the expense of a dose of IV acetaminophen is orders of magnitude greater than oral, and we're trying to use oral medicines as much as possible in our ERAS protocols. But for certain people, our esophagectomy patients and total gastrectomy and Whipple patients, we really like to use the IV acetaminophen in the early postoperative period, though frequently we'll give these people a dose of 1,000 milligrams of oral acetaminophen shortly before the beginning of the operation.
I think one of you had made mention, we had discussed briefly, you know, talking about site management, wound management, those types of things. I think, John, you had mentioned some, you know, maybe the use of some of these subcutaneous catheters where you can infuse either a local anesthetic agent.
So as we discussed earlier, we've gotten away from epidurals, although we will still use them in limited application with just local anesthetics, so we avoid narcotics. There's transverse abdominis plane blocks or TAP blocks that are useful in some settings, and I've done a lot of those for abdominal surgeries of all kinds. And then there's really even more local than that is a subcutaneous catheter where the surgeon puts the catheter at the time of surgery and tunnels it out, and then we keep infusions going as well. And I think those are very often TAP blocks as well. It's just placed at the time of surgery. So if that's where you place the catheter, that's probably the best way to do that. And then that gives us a way to maintain a non-narcotic analgesia into the post-op period. You know, there are some other agents as well. There's intravenous lidocaine, which is extremely cheap, and the Brits use it a lot. They actually use it on the floors.
We use it.
Yeah, if you want to start an animated discussion, bring that up in a private practice hospital, say you want to take it to the floor, and you'll get all kinds of, but you know, those are things we need to work through. Intravenous magnesium is very cheap and very effective. And there's ups and downs about all these things, but Each is, like we were talking earlier, alvimipam is one bullet in your holster. There are a lot of multimodal analgesic agents that I think we need to optimize moving forward, and there's a lot of work around those things.
So the role of intravenous magnesium is just to maintain intravascular volume?
No, it actually
No.
is analgesic.
It's analgesic.
Yeah.
As is esmolol, which is a short-acting beta blocker. We can use that as infusions for pain. So there's a lot of things that don't affect the gut, and that's where a lot of the anesthesia literature is going. And I think we'll see more and more of that. And what part they play in these protocols, remains to be seen. But I think we have to vary our protocols based on the patient's specific history. To your question earlier about who's a candidate, who is not, I think they need to stay on our protocols because it's evidence-based best practice pathways, but we vary them by the individual's basic needs or guidelines or whatever we want to call it based on their specific history.